Well, hello, and thank you for attending our final presentation in our breast cancer awareness videos that we have going on for the month of October. We are excited to have our two guest speakers with us today. Just a couple of announcements before we get started. If you have any questions, please feel free to place them in the chat box. We will have a question and answer time at the end of the program, and we'll be happy to get to all of those questions that you might have. And before we get started, I'd like to share a message with you from our compliance department. The content in this presentation is not intended to be medical advice, and the viewer should consult their physician should they have any questions. Viewers should not rely on information contained in this webinar for urgent medical needs. Additionally, if you think you may have a medical emergency, call your physician, go to the nearest emergency department, or call 911 immediately. Never disregard professional medical advice or delay seeking care because of information contained in this webinar. Today's session is What Breast Imaging Should I Do for Screening? And it will be presented by Dr. Shannon Falcon and Dr. Kimberly Fanero. Dr. Falcon is an associate member at Moffitt Cancer Center and an associate professor at the University of South Florida's Morsani College of Medicine. She is a board-certified radiologist who is subspecialty trained in breast imaging. Dr. Falcon's clinical focus is in the multimodality imaging approach of breast cancer detection and management. She routinely gives lectures on breast cancer screening and prevention. Dr. Falcon's research interests include appropriate and optimal utilization of breast imaging techniques. Dr. Fanero is a fellowship-trained breast radiologist and has been practicing at Moffitt since 2017. Dr. Fanero earned her MD at the University of Florida College of Medicine in Gainesville. She completed a diagnostic radiology residency at the University of South Florida Moffitt Cancer Center, followed by a breast imaging fellowship at Moffitt Cancer Center. Dr. Fanero's clinical interests include resident, fellow education, and quality assurance. She is committed to communicating effectively with patients and their healthcare providers to ensure the best care possible. Ladies, the stage is yours, and please proceed.
Okay. All right, there we go. Now you can hear me. Thanks for the introduction and thanks for having us. We look forward to this every year and really excited about sharing this information with you. I just need to figure out how to get my screen shared. So give me a second here. And here we go. Got too many things open at once. All right, so hopefully you're seeing my screen now, and I'm going to present the first half of this talk, and then Dr. Fanero will take over. And so what I'm going to present to you is screening mammography. And what we'll go through today is, first we'll start out by defining what a screening test is and what a mammogram is. We'll discuss the benefits and risks of mammography, our screening recommendations, and disparities among screening. So what is a screening test? It's performed to find disease in an asymptomatic population. So mammography is our screening test because it finds the disease with very little risk. And this is not all that different from a pap smear that looks for cervical cancer, a colonoscopy that looks for colon cancer, and even something as simple as a blood draw to check your cholesterol for heart disease. No screening test is 100% accurate, so we do need to always keep that in mind, but we still want it to be really good at finding the disease, which mammography is, and I hope to prove that to you today. So a mammogram is pretty much just an X-ray of the breast. We obtain 2 images of each breast on your typical screening mammogram. We get a CC view from top to bottom and an MLO view that is diagonal from the side. CC stands for craniocaudal and MLO stands for mediolateral oblique. This while it is like an X-ray, it's super high resolution. It's one of the highest resolution, if not the highest resolution of any imaging exam performed, so that we can see tiny, tiny things like microcalcifications. So mammography is the only test proven to reduce the risk of dying from breast cancer. Breast cancer deaths have decreased by 40% since annual mammography began in the 80s, and it's reduced the risk of dying from breast cancer almost in half. So it's had a really, really great impact on mortality. The goal here is early detection. So having that really high resolution makes it able for us to find cancers when they're super small before they can be felt, and oftentimes before they're even invasive. So in this way, the cancers are easier to treat, that cost less, and the treatment is less harmful to the patient. Just need to move something on my screen that's in my way here. And so also by finding it in this early stage, 98% of breast cancer patients survive. So it really can be a curable disease when we find it in this early stage, which is often before it can be felt. So as an example of something that we might find that you wouldn't be able to feel or have any inclination about otherwise, are microcalcifications. And oftentimes we see microcalcifications so small and faint that you wouldn't be able to see it on this computer here because we have to use special monitors. So this is about as small as I felt I could show you, and you can maybe still appreciate it. But you'll notice here in this breast, this is the right breast, and this is that MLO view, this is the CC view. There's this group of calcifications. And even though this is considered high resolution, it's still not good enough for us. We want even a closer look to really evaluate the shape of those calcifications and help determine how suspicious they are. And in this case, we could see the calcifications more clearly with a magnification view. This is one of those additional views you may be called back for from a screening mammogram. And we see that they warrant biopsy, and this was biopsied and came back as a high-grade DCIS. An example of a small mass is shown here, also coincidentally in the right breast. So it's this little white mass on the, again, the MLO view and the CC view that can be a little bit difficult to see because of the surrounding tissue. And so that's part of our job, is getting good at pattern recognition and finding these masses hiding in tissue. Sorry, and that came back as an intraductal carcinoma. So what about tomosynthesis or 3D mammogram? You hear about this a lot. We do them routinely at Moffitt on all of our imaging at no extra charge. And 3D is a little bit of a misnomer. It's really called tomosynthesis, and it's actually multiple thin sliced images obtained through the breast. So the camera goes through a number of angles, rotating around the breast, and then these multiple images are put together to recreate a mammogram of the breast. And what's great about this is then we can see even finer detail because we can go slice by slice. In this way, we can sometimes find a few more cancers. And then what may be even more significant is that it decreases the number of false positives, meaning it decreases the number of times that we bring you back for those additional views to work something out that ends up just being normal tissue. So we can see through that normal tissue, like how I showed you that it can be difficult to find those cancers in the tissue. We can see through that tissue to hopefully find it more easily or recognize that it's just normal tissue. So an example here of tomosynthesis, just to get an idea of how we might find it useful to find cancers. We have a 2D image here, so a regular mammogram. And then this looks all fuzzy because this is a video going through the different slices, thin slices of the breast. So let's see. Well, this does usually work for me. It doesn't seem to want to work today, so I apologize for that. But what we found on a tomosynthesis slice, so this is just one slice in the middle of the breast, was this tissue that stands out from the rest. And I think that we can all agree it would be difficult to see among all the other white tissue here. And so this, we were able to find it as being different from the rest of the breast tissue, and this was an invasive lobular cancer. So hopefully I've shown you that mammography is really good at finding the disease, but what about the risk? Is it worth it? Well, what comes up most often is radiation dose, but the radiation dose is tiny. It's so small, in fact, that we can't even calculate the risk of cancer from that radiation. It's really the same as just a few weeks of natural background radiation. So just sitting here in front of your computer, your phone, with the sun to your back, just your surrounding environment, you're being exposed to radiation. So it's about the same as that, or what I like to tell women is it's the same as getting on an airplane to California. We don't tend to think about that too much. And so maybe we shouldn't think about the risk with mammography either, because it's that small. Overdiagnosis is a buzz term you may hear right now. And basically what this means is that we are able to find these cancers so small that we're finding them maybe in situations where it's creating more harm than help. So it's such an early small cancer that because of the patient's age or because of additional diseases or life-threatening things that they have going on, it may not be worth finding that small cancer and treating it. The problem is it's a really small minority of the cancers we find. We estimate that it's probably less than 10% of the cancers found. And B, at this point, we just don't know which cancers are going to grow quickly versus those that are never really going to progress during that woman's lifetime. We can't distinguish, and what we do know is all cancers grow. So we do go ahead and treat those cancers. So there is a temporary discomfort, but I think that it usually resolves pretty quickly after having the mammogram. There's certainly more uncomfortable medical things I think we go through as women. And then anxiety is often cited as a harm. I think they underestimate the strength of us women. And I think that most of us can wrap our head around that. And of course, the fear of the unknown does create quite a bit of anxiety for all of us. But data show that there's no long-lasting effects of this anxiety on women's mental health or physical health, and that even women who have gone through the process and had a lot of anxiety associated with it would still prefer to have that mammogram and that reassurance from the mammogram than not have to deal with the anxiety. So a lot of the anxiety surrounds the follow-up of having a mammogram and what comes of those studies, those callbacks that I had mentioned. So let's just quickly run through that just to show that it really is the minority of women, and not to minimize their experience, but most women out of 100, about 90 are going to be told that they're normal. So most women are going to be told that they're normal. 10 will be asked to come back for additional imaging, whether it's an additional mammogram, ultrasound, or both. Of those, 2 may be asked to return for a follow-up exam just to keep an eye on things, whereas 2 may be recommended to have a biopsy. So we're looking at 2 out of 100 typically would be recommended for a biopsy, and then maybe one of those would be diagnosed with a breast cancer. It's about 1 per 200. So even out of this 100, we may not find a breast cancer. So who should be screened? There's a lot of controversy that you hear surrounding this, and so hopefully I can provide some clarity. Your breast health specialists, meaning your surgeons, your oncologists, your gynecologists, your breast imagers, we all agree that all women aged 40 to 84 years old should have an annual screening mammogram. And the reason that we advocate for this is because we know that it saves the most lives and improves quality of life the most. Again, going back to that hope for an easier treatment plan. And across all organizations, it's recognized that the most lives are saved at 40. It's just that you may hear that some suggest starting at 50. Having said that, we know that there's a sharp incidence and increase, about twice as many breast cancers being diagnosed at 40 as compared to women in their 30s. And so really we put that emphasis on starting at 40. Some organizations may advocate for every other year. We, again, your breast specialists, would argue that annually makes sense because it saves over 70% more lives than doing every other year in women 50 to 74. Now, this really applies to all women. Some women think that maybe they shouldn't follow these rules or recommendations because they don't have any risk factors. But keep in mind, 75% of women diagnosed with breast cancer have no family history, and most do not have any identifiable risk factors other than two that we all have, which is A, being a woman, and B, getting older. So I've already mentioned a little bit about why starting at 40. And so to dive a little bit deeper into that, as mentioned, we save the most lives. And nearly 20% of breast cancers are diagnosed in women in their 40s. It's really, that decade really isn't different from the other decades that are recommended for screening. It's the number one cause of death in women 45 to 54, and the number one cause of cancer death in women 40 to 49. We know that most of the women who die from breast cancer within this age group were not being screened. So again, it's saving lives. And waiting till after 50 is particularly harmful because there are quite a number of women in their 40s who are developing breast cancer, and it particularly harms minority women, which we will get into in just a few minutes. So to wrap up the other end of our recommendations, why continue after 74? And I mentioned 74 because that is what some other organizations may put for their guideline. And as you may recall, we recommend up to 84 or 85. And the reason for that is because at the age of 75, the average American woman will live another 13 years. So let's make those another good 13 years. We're going to save about 25% of women who are dying of cancer, breast cancer deaths after 74. So it really doesn't make sense when we're thinking about the population in general to withhold such a low risk exam from this older age group, unless, again, maybe they have some kind of other comorbidity that would affect their lifespan and maybe make it not really reasonable. So I touched upon how following other guidelines may particularly affect minority women. Well, we know that there overall is a disparity by race or ethnicity in the United States. And this is due to a variety of factors. The benefits of screening are not evenly distributed. A lot of that has to do with the underutilization of screening and some of the barriers related to screening, such as lack of a regular PCP or primary care physician, access to quality care. So maybe they don't have the latest technology where they live. There may be some pain, embarrassment, related to cultural ideologies. Of course, can be socioeconomic factors, just an overall lack of knowledge, and communication gaps. If it's difficult to talk to your healthcare providers, it may be difficult to understand what is needed. So we know that it's not quite distributed evenly, but also the benefits, that decreased mortality rate that we see is not quite as drastic in the other minority populations as it is in the non-Hispanic white population. And that has a lot to do with the follow-up and the the treatment plans related to a cancer diagnosis. So there's really a lot of factors here, and we really need to get better at screening and treating our minority patients. Also, what's interesting is minorities are more likely to be diagnosed at a younger age as well as a more advanced stage. So it's not those early cancers. So we really need to be thoughtful about getting the screening in at that 40 years of age. So looking a little more specifically at the non-Hispanic Black women, for a long time, it was thought that Black women didn't have quite as high of the incidence of breast cancer, which means the number of newly diagnosed breast cancers, which is this light pink bar here. But in 2012, they caught up to the non-Hispanic white women. And then it started to decline just a little bit. It's still pretty similar to white women. However, you'll notice by the dark pink column, which reflects mortality or the disease-related death, that their likelihood of dying from breast cancer is higher. So their incidence is similar to slightly less, but yet they're more commonly dying from it. So why is this? And again, it's not going to be just one answer that we can fix. One is a risk perception. Black women or African-American women do have a higher have a risk of having a BRCA mutation, and culturally that's maybe not very well understood. It may often be labeled more of a non-Hispanic white woman's disease, but the BRCA mutation is often seen in Black women as well. Another issue is that they tend to get more aggressive types of cancers. A common example would be a triple negative cancer. You may hear that term, and it tends to present larger at a later stage of disease and recur more commonly. And so it's a little bit harder to treat. As mentioned, there's an underutilization of the screening tools for all the factors previously mentioned, and then less optimal treatment plans. Then just to wrap up our discussion on disparities in screening, let's run through a few more of our minority groups. So Hispanic American women also have lower rates of screening, and they do have lower incidence of breast cancer, but because of these lower rates of screening, they also have it's also a leading cause of cancer death. So even though they may not have breast cancer as commonly as the non-Hispanic white women, it's still the most common cancer and the leading cause of cancer death in these women. And of course, all the other factors already mentioned play a role, but language barriers is a big one. And similarly, this holds true for Asian Americans, who also have a lower rate of screening, despite it being the second leading cause of death. Native American women, it's a small population, but this is where we are having some of our biggest screening crises, so to speak. And a lot of it has to do to access and unique barriers that Native American and Alaskan women have, but they have the lowest rates of screening, and this has not changed over many, many years. And despite this being the most common cancer, they continue to have the lowest rates of screening. And even though their screening has increased, there has been no change in the mortality rate. So we have a lot of room for improvement there. The LGBTQ community has unique needs as well. There's a lot that's still misunderstood. And I think that this population and physicians both have some misunderstandings, and we need to have better communication and also make a more open environment for this patient population. And finally, the physically disabled also tend to have lower rates of screening, and a lot of that has to do with the more obvious physical limitations that they may have with getting imaging. So what if you're high risk or dense, or when you do have that family history? Well, I'm going to leave that for Dr. Finero to discuss with you. What I really want to emphasize is that mammography is our gold standard. There's no replacement for an annual mammogram and clinical breast exam and a monthly self-breast exam. And supplemental screening may be something that you should think about and discuss with your doctor. So I'll let Dr. Finero take over from there and discuss that with you. Thank you so much.
Great. Thank you so much. I'm going to share my screen. I did get a pop-up saying a computer restart is required in 29 minutes to install software. So I've got to get done before that. All right, let me share my screen. Put it- All right, can everyone see the big blue screen? Hopefully. All right. Well, it's a pleasure to be talking with you this year. As Dr. Falcon said, this is always fun to do each year. So Dr. Falcon did a great job going through screening mammography, the reasons behind it, why it is our tried and true test to look for breast cancer in asymptomatic women. So I'm going to be talking about supplemental screening today. So I know you heard my little bio, but I'm happy to be at Moffitt. I've been here since 2017. Outside of being a breast radiologist, at home I'm busy with my kindergartner and third grader. So it doesn't stop at home. So here's our outline of what we're going to talk about. So we're going to go through what is supplemental screening and who may need it. We're going to talk about the risk factors associated with breast cancer and the risk assessment. And then the most common supplemental screenings we're going to touch on: screening ultrasound and screening breast MRI. There are some others, such as contrast enhanced mammography, that I'll just speak a little bit about later, but we're not going to go in any great detail on that, since that is something that Moffitt does not offer. In the future, we may, but it's something in the years to come we'll get more data and understanding about. So what is supplemental screening and who may need it? So let's define that. So supplemental screening is screening that's performed in addition to screening mammography. We already know that screening mammography saves the most lives. It is our tried and true test, as Dr. Falcon went through. But some women have multiple additional factors that, mammography is great, but there are limitations. And so with women that are high risk or that have strong family histories or dense breast, a multitude of factors that we're going to go through, they might need something else to pick up those very tiny cancers that might not be able to be seen on mammography. And so Dr. Falcon also talked about the digital breast tomosynthesis, so that 3D quote unquote mammogram that takes the slices through the breast. So when that first came out, that was almost used as a supplemental screening, but now that has become a pretty standard exam. And at Moffitt, all of the screening mammography that is done is performed with digital breast tomosynthesis. And as we saw, the DBT, it increases the cancer detection rate and decreases those callbacks or those false positives where we're calling back something that's just tissue or something that's benign. So all of the Moffitt mammograms are getting that DBT for screening. And ultimately, the goal of all screening is, again, to detect asymptomatic cancers. And so same thing with supplemental screening. We want to find those asymptomatic cancers that are not able to be visualized on screening mammography. And so there's a multitude of reasons why a cancer would not be seen on a mammogram. A couple of those reasons, which are our most common ones, is actually a size related thing. Patients may have a very tiny mass that's hard to see, and that can also contribute or be contributed by the overlapping dense tissue. And so you may have heard about fatty versus dense breast. There's been a lot of talk about it in the media. There's legislation, both state and they're talking about national legislation about breast density law. So women know their density. And so just as an example to show you the difference between a fatty breast and a dense breast. So each patient has their own distribution of the amount of fat and fibroglandular tissue in their breast. So on the left here, this is an example of a fatty breast. And fat on a mammogram is dark, whereas breast tissue is bright. And so you can see in this breast that has very little breast tissue and mostly fat, we can clearly see that there is a mass sitting in this fat, and it's a small mass, and we're able to see it quite easily. So patients with fatty breasts, it's much easier for us to see those small masses. Whereas this patient here has a dense breast. You can see this patient has a lot of white breast tissue, and then this is the fat. And so you can see there's a mass at the edge of this tissue and fat with these little spicules coming out. And this mass is much larger than the mass here on the left. And so if we could just imagine this small mass sitting in this dense tissue, we wouldn't be able to see that unless we had some other findings associated like calcifications or spiculations that we could pick up on those tomosynthesis images. So this is why breast density is a challenge to mammography. And so patients with dense breast can, on occasion, depending on other risk factors, need supplemental screening. So who needs it? Women at elevated risk of breast cancer due to a variety of factors, both major and minor risk factors that we're going to go through. So some of the risk factors associated with breast cancer. So the most important risk factors are being a woman and aging. And so those are non-modifiable. We can't change that. And so the main risk factors, you can't change your diet. For the major risk factors, you can't change your exercise patterns. I mean, those can have an effect, but the main risk factors are going to be being a woman and getting older. And so over 70% of women that have breast cancer, those are their only risk factors. And so that's why every woman over 40 should undergo annual screening mammography, because the majority of women that are diagnosed with breast cancer don't have a family history. They don't have any other risk factors. They don't have the BRCA mutation. And so there's so many times where I'm performing a biopsy on a patient, or we're doing a procedure prior to her going to surgery where she says, I'm the only one in my whole family that was ever diagnosed with breast cancer. I never thought it would happen to me. And I always tell her, I said, well, that's actually, you're in the same boat as most women. Most women that are diagnosed with breast cancer don't have any other risk factors. And it's surprising because a lot of our media and the press talks about family history and BRCA mutations, and those are important risk factors. But just to make it clear that most women don't have any other risk factors. Now, for those that do have risk factors, those are important. And so we want to identify factors that increase the baseline risk. And those are going to fall into moderately higher risk or slightly higher risk. And so this little pie chart I thought was helpful that just shows the breast cancer by breakdown. So sporadic, as we were talking about, no other risk factors, majority of breast cancer cases. Familial, about 15 to 20%. So that means maybe your mom had breast cancer, your sister, your grandmother, but no known genetic cause. And then the hereditary breast cancers that we hear a lot about, like the BRCA mutations, those really only account for a small amount of overall breast cancers. So the strongest risk factors associated with developing breast cancer that we know about are going to be some mutations and some other factors. So having a BRCA mutation that you know about is a risk factor, or having a relative, a first degree relative, so a mom or a sister or a daughter that has the BRCA mutation, but you yourself have been untested. Those confer a very high risk of developing breast cancer. A lifetime risk of greater than 20 to 25% defined by risk models. So we'll talk about those here in a little bit. But that shows that you have a significantly higher risk factor for developing breast cancer than the general population. Other factors, something called the Li-Fraumeni syndrome or the P53 mutation in first degree relatives, radiation to the chest, typically performed for lymphoma treatment between the ages of 10 and 30 years old, and some other genetic syndromes. So these are the strongest risk factors associated with developing breast cancer. And these patients should always, always, always be undergoing supplemental screening and and having it done with MRI, because that's going to be our most sensitive test that we'll talk about later. So these patients should always be captured into supplemental screening. So what are some other risk factors? So some moderate risk factors, having a personal history of breast cancer. So you have had a breast cancer, you've either had a mastectomy on one side or a lumpectomy. That's going to increase your risk for another cancer. We talked about having a first degree relative, so mom, sister, daughter. That's a moderate increase in developing breast cancer. Having a prior high risk breast biopsy. So that means you've had a breast biopsy with some atypia, maybe atypical ductal hyperplasia or atypical lobular hyperplasia, things like that. A lot of times those high risk breast biopsy sites are removed with surgery because there is a risk of surrounding cancer there. So that's a moderately high risk factor. Being overweight or obese is also a risk factor, and that is thought to be related to increasing your overall estrogen state. So having fat cells, the adipose tissue, it increases estrogen in the surrounding tissues. And so it has been shown that being overweight or obese can be a risk factor. So some of the lesser risk factors that don't play in as heavily is having a distant family history. So maybe an aunt, a grandmother, or a cousin, having previously been on hormone replacement or currently on them. Again, because that means your body is exposed to more estrogen, your breast tissue is exposed to more estrogen. Early menstruation and late menopause and delayed childbirth or never having a child. Again, that means that you've had an uninterrupted, very long period of estrogen to the breast tissue. Alcohol use, breast density. So breast density, we talked about how it can mask small cancers, but breast density in and of itself is actually a risk factor for developing breast cancer. So having more dense breasts, those patients actually have a higher baseline risk than those with a more fatty breast. Ashkenazi Jewish heritage, race, particularly African American, as Dr. Falcon discussed, they have a higher chance of being diagnosed early with more aggressive subtypes of disease and a higher death rate, and physical inactivity. So these are all risk factors. So risk assessment is important. And one thing that Moffitt, I think, is doing a really great job is all patients that are coming to get their screening mammograms at Moffitt are going to be filling out on an iPad all of these risk assessment models. So there's multiple different models. Some of the ones that you may have heard of, there's a Tyrer-Cuzick, there's a Gale model, there's BRCA Pro. So basically it's a questionnaire and you fill in that information. So you fill in your family history. You fill out if you've had any genetic testing, if you have a known genetic condition. You fill in when you started your period and when you went through menopause. And so all of that is filled into those risk assessment models. And it gives you both a 5-year and a lifetime risk of developing breast cancer. So then we know where you fall, because we already know that patients with a greater than 20% lifetime risk of breast cancer should be getting supplemental screening. And so then you know that you need that supplemental screening. And so your doctor can help you to determine that lifetime risk. Just ask, if you go see your primary care doctor, your OB-GYN for your annual exam, say, I'd like a risk assessment. These models are available, and most of them are free. And if you come and get your mammogram at Moffitt for screening, you're going to fill this out anyway. And so all women, especially Black women and those of Ashkenazi Jewish descent, need to be evaluated for their breast cancer risk. And we are recommending that that be done no later than age 30. And that is because while we start typical screening mammograms at age 40, Women with risk factors, with a higher lifetime risk, need to actually sometimes start screening sooner than that. So some women may need to start their mammograms at age 30. Some women may need to start their breast MRIs at age 25. And so we want to capture those women when they need to begin that screening, so that all of those benefits from supplemental screening of finding those small, easily treatable breast cancer can occur. And so the different risk assessment models will basically put you in to 3 risk categories. So average risk is a lifetime risk of breast cancer, less than 15%. And you might be wondering, well, if I'm average risk, how come it's that high, around 15%? Well, we talked about the main risk factors are just being a woman and getting older. And so no one's going to have a risk, a lifetime risk of less than or of 0, unfortunately. Intermediate risk is falling between 15 to 20%, and then our highest risk patients have a greater than 20% lifetime risk. So let's talk now a little about what tools we can use for that supplemental screening. And so we've talked about risk assessment. So once we know what our risk assessment is, we know if we need supplemental screening. And so the 2 most commonly used supplemental screenings are going to be screening breast ultrasound and breast MRI. So ultrasound is a type of imaging exam that uses sound waves to produce images of tissue. It can be performed anywhere in the body, but we're talking about it of the breast tissue. One of the benefits of screening breast ultrasound is there's no radiation, even though we know that the radiation from a mammogram is exceedingly low, as Dr. Falcon pointed out. It's a painless exam other than some mild pressure with the probe site. It doesn't require compression like screening mammography. It's a pretty fast exam. It can be done in about 15 to 20 minutes. A woman lies on her back, like in this picture, places her arm above her head, and then the medical sonographer will take images and assess the breast tissue. As far as how many additional cancers do we find? So we know that screening mammography finds around 5 per 1,000 cancers, as Dr. Falcon had pointed out. So when we perform screening breast ultrasound, in addition to screening mammography, we're going to find about another 4 to 5 cancers per 1,000 women screened. And so we'll get up to maybe around 9 or 10 cancers per 1,000 women screened. So we've kind of doubled it. Now, screening breast ultrasound isn't perfect though, because ultrasound, it can evaluate characteristics and masses, but sometimes we see things and it's not entirely clear. Is it a suspicious mass, or is it something like a cyst with some debris in it, or just the way the tissue pattern is? And so there's a higher chance that we may see something and not know exactly what it is and recommend a biopsy for a finding that ends up being benign. So there's a higher false positive rate. So screening breast ultrasound is also not suitable for patients with a high lifetime risk. So the patients that we're talking about with that high lifetime risk are our patients with the greater than 20% lifetime risk, are known genetic mutation carriers. And so those patients really should be undergoing breast MRI for the reasons I'm going to talk about in just a second. But screening breast ultrasound, it does have its role, but we really here at Moffitt recommend screening breast MRI because it's just a more sensitive test that finds more cancers with a higher specificity, which means we're not biopsying benign findings. So screening breast MRI, again, like ultrasound, it does not require any radiation. Some of the downsides of it are it does require having an IV placed, and it does require contrast administration with a gadolinium-based contrast agent. It takes about 30 minutes to an hour, and you do have to lie on your stomach and lie still. So this little picture depicts this woman lying on this table here, and her breasts are hanging down. She's cushioned, she has a face rest, and so, but the breasts hang down. This table then slides into the bore of the magnet, and the patient is in there while the images are acquired. And again, that takes on average about probably 40 minutes or so. So you have to be able to lie still. Patients that have claustrophobia maybe have trouble with this exam as well. But just to note how important this test is. And it really does outperform mammography and ultrasound in all women at increased risk of breast cancer development. So we know that mammography finds about 5 per thousand cancers. Screening breast ultrasound finds about 4 to 5 per thousand more. But look at this, MRI finds 20 additional cancers per thousand women screened. It's 4 times that of mammography or screening breast ultrasound. So it's exceedingly good at finding additional cancers and finding cancers that are not able to be seen on mammogram, either due to small size or masking of tissue or other factors. And so, like all screening exams, however, breast MRI is not perfect. It can miss some cancers. There are false positives on occasion associated with it. And so some of the things that we might not be able to see on a screening MRI are things like those microcalcifications. And that's why it's so important to pair both a mammogram and the supplemental screening together. We never just want to do one. We want to have them together because we can correlate on both images. If there's calcifications, we might not be able to see those in areas enhanced on an MRI. Or if there's enhancement on the MRI, we might not be able to see that on a mammogram. So they really are correlative exams that need to be read together. And so this is an example of a MRI image. Here's the tissue. This dark stuff here is the fat. That's the patient's chest wall. And this is an example of what that enhancement looks like. So the patient is given contrast. We take images after the contrast administration because we know that tumors, they take up that contrast. They have leaky blood vessels. And so the contrast is taken up and then it washes out. So we get an idea of basically how the breast tissue is responding to blood flow and the contrast through the blood flow. And so we're able to see that enhancement there. And if there's something seen on MRI that's not seen on mammogram, we're able to biopsy it that way as well. And so screening breast MRI really is our best supplemental screening modality. And ultimately, kind of some final points, no screening test is perfect, including supplemental screening. And that's why we use them in conjunction with your annual screening mammography. So women with an elevated risk of breast cancer, based off those risk assessments, need to have their additional supplemental screening. And so having a formal risk assessment is really going to be the best way to know if you're at increased risk. And so we recommend all women undergo a risk assessment to make sure you're getting that additional screening if you need it, especially our minority women and those of Ashkenazi Jewish descent. So talk to your doctor about a risk assessment. Again, here at Moffitt, all of our screening mammography patients are having that filled out, and that information is provided at the bottom of their report, both sent to their doctor and their own report that comes to them. And so I will end it there for any questions.
Well, thank you both. That was actually quite informative and I appreciate that. So we have a question or two. If ultrasound is good as supplemental screening for a non-mass DCIS finding?
Oh, I'll take that one. That's a great question. And so ultrasound, that's one of the drawbacks for ultrasound. So DCIS, it can on occasion present as a mass, but it's more commonly going to present as something called non-mass enhancement or on mammogram as calcifications. And ultrasound is not great at seeing small microcalcifications that aren't associated with a mass, and it's not great at seeing that non-mass enhancement. And so we are able to find DCIS much better on on a supplemental screening MRI than on a screening breast ultrasound.
Thank you. And another question is, for those patients with post-mastectomy with breast reconstruction, can an MRI/ultrasound be performed on those breasts, knowing that mammogram is not applicable?
I can take that one too. And so that's a great question too, because we do have women that are undergoing it depends if, if they still have their breast or one breast or have had a bilateral mastectomy. And so we do have women that have either a significant amount of tissue left or they still have a contralateral breast that do undergo supplemental screening with MRI. And an additional thing that we can evaluate for on supplemental screening MRI is if patients have been reconstructed with silicone implants, we're able to see those silicone implants very nicely. And it's actually the gold standard for evaluating implant integrity. So we're able to kind of kill two birds with one stone by doing that.
Thank you. And does Moffitt screen differently from other facilities? Why does Moffitt want their own screening film?
All right, so I'll take this. Well, I think there's a few things going on here. First is it different? Well, all screening exams should at basic have the same 4 views, so that shouldn't be any different. Now, not every place is going to have tomosynthesis or 3D. We do that routinely, like I said, at no additional charge. Some places do it for an additional charge. Some places don't do it at all. So that's still emerging as a standard of care, and it's certainly more common now, but that's one potential difference. Now, why would we want our own film done? We do routinely review outside films. It's part of our daily duties, but there is some quality differences among facilities, whether this is due to a difference in equipment. Of course, we're dependent on our technologists and how good they are with positioning and taking the images. And so unfortunately, we do see a wide discrepancy there. And this is not unique to Moffitt. A lot of patients who go to other facilities in particular for cancer care, there are places, my understanding is they won't even review the outside films to see if they're adequate. They just automatically start over. We will not automatically start over. We will review them. And if we feel like that they're not high enough quality where we can find those small differences and or isn't covering enough of the breast tissue, I would say those are 2 of the reasons that we most commonly would want to get our own films. And we don't want to make decisions on films that we don't think are benefiting the patient. So that puts everybody at risk.
All right, thank you so much.
Sure.
I see no further questions in our in our chat box, so we will go ahead. Well, actually, Ms. Evans says all makes sense. Thank you so much and great presentation. And I would echo that as well, Ms. Evans. So we want to thank you to our presenters for providing this educational session for us today. And thank you to our participants for joining us. We look forward to having more webinars next year during our Breast Awareness Month of October. And we hope you will be able to join us then. Thank you so much, and everyone have a great day.
Thank you.
Thank
Take
you.
care.
Thanks.
Bye-bye.
Bye.